The question of whether a sudden change in one's body is simply the result of natural aging or the sign of a far more dangerous event such as a stroke has haunted countless families across the world, and it is a question that carries consequences so profound that the difference between hesitation and swift recognition can alter the course of a life forever. In the quiet of an ordinary morning, as a person sits down with their newspaper or their cup of coffee, an unexpected weakness in the arm, a momentary slurring of speech, or a fleeting loss of balance may appear with startling immediacy, and the natural tendency is to dismiss it as tiredness, as clumsiness, or as a minor symptom of advancing years. Yet history and medicine alike remind us that such dismissals can be catastrophic, for aging is a gradual process marked by slow and predictable changes, while stroke is an abrupt, violent interruption in the brain's lifeline that strikes without mercy or warning. The introduction to this subject must therefore impress upon the reader the singular importance of recognition, because recognition is power, and power in this context means the preservation of independence, dignity, and in many cases, life itself. To understand why the difference matters, consider the scale of the problem. Strokes are the second leading cause of death globally and the leading cause of long-term disability, robbing millions of the ability to speak, to walk, to work, and to engage fully with those they love. The tragedy is not only that strokes occur, but that they so often occur with warning signs that are ignored, misattributed, or minimized, under the comforting assumption that nothing urgent is happening. By contrast, the changes of aging are insidious, creeping forward in increments so small that they are barely perceptible day to day. The stiffness in the joints that deepens slowly over years, the gradual fading of memory, the declining swiftness of gait, these are the rhythms of natural life unfolding, and while they present their own challenges, they rarely demand immediate emergency action. The introduction must therefore anchor the central truth of this discussion. The difference between aging and stroke lies not merely in the nature of the symptoms, but in the velocity with which they appear. What emerges slowly is almost never a stroke. What arrives suddenly should never be ignored. This truth, however, is easier to state than to act upon, because fear, denial, and uncertainty cloud judgment in those crucial first minutes. Families often find themselves frozen by indecision, torn between calling emergency services and waiting to see whether the symptom will pass. And in those moments, the brain cells of the sufferer are dying at a rate of nearly 2 million per minute. A fact that underscores why time is not merely valuable but absolutely decisive. Consider also the psychological weight of aging in modern society. Many older adults are reluctant to acknowledge frailty, and many families fear overreacting, especially when healthcare systems are costly or emergency services daunting. Thus, the theme of this introduction is not only medical but human, for it is a story of perception, of decision, and of courage to act when hesitation feels safer. To capture the full scope of the issue, let us frame it in terms of three intersecting realities: the biological difference between aging and stroke, the social patterns of misinterpretation, and the individual stories that illustrate both the peril of delay and the triumph of timely recognition. Biologically, aging is a continuous remodeling of tissues, vessels, and nerves, a process whose rhythm is measured in months and years, while stroke is an acute disruption of blood flow within the brain caused either by clot, ischemic stroke, or by rupture, hemorrhagic stroke, and its arrival is measured in seconds. Socially, the tendency to minimize or misinterpret sudden symptoms as benign arises from a culture that often normalizes decline in older adults, without equipping people to distinguish between benign and catastrophic change. Individually, every family touched by stroke can recall the moment when the first symptom appeared and the critical decision that followed, a decision that would later be remembered with gratitude or regret depending on whether help was summoned immediately or delayed. Therefore, the introduction must also serve as a call to awareness, urging every reader not merely to absorb knowledge, but to internalize it as an instinctive response. When the arm suddenly weakens, when the face suddenly droops, when words suddenly tumble out in confusion, the correct reaction must be automatic: to recognize stroke and to call for emergency help without hesitation. This cannot be overstated, for the difference between arriving at the hospital within the therapeutic window and arriving after it has closed often determines whether modern medicine can reverse the stroke or whether the damage will be permanent. Treatments such as tissue plasminogen activator, TPA, for ischemic stroke or surgical intervention for hemorrhagic stroke are effective only if administered swiftly, and each minute lost reduces the chance of recovery. Yet knowledge alone is not enough. The introduction must also emphasize that repetition, storytelling, and emotional connection are necessary to ingrain this knowledge so deeply that it overrides panic in the moment of crisis. That is why communities and health educators repeat acronyms like FAST, face, arm, speech, time, and why stories of survival or tragedy are shared, to ensure that recognition becomes second nature. Furthermore, one must recognize that the boundary between aging and stroke is not always clear to the untrained eye, which is precisely why erring on the side of caution is not only reasonable but essential. Even physicians use advanced imaging to confirm stroke, so expecting families to be certain before calling for help is unrealistic and dangerous. The guiding principle, then, is simple. If a symptom is sudden and unusual, it must be treated as a stroke until proven otherwise. By beginning with this framing, the introduction establishes the stakes, the science, the human dimension, and the imperative of immediate action. It situates the reader within the lived reality of countless families who have faced the same uncertainty, and it challenges them to prepare now, so that if the moment comes, they will act without hesitation. In doing so, it bridges the gap between abstract medical knowledge and the lived human experience, preparing the ground for a deeper exploration of the differences between aging and stroke in the sections that follow. When attempting to distinguish between the natural process of aging and the sudden onset of a stroke, the most fundamental and perhaps most reliable clue lies in the dimension of time, for time is not only the measure of our days, but also the sharpest dividing line between gradual decline and catastrophic interruption. Aging, by its very essence, is a slow erosion and adaptation, a progression that unfolds over months, years, and decades, with changes so incremental that they are often invisible until retrospect reveals their accumulation. Stroke, by contrast, is violent in its immediacy, a sudden deprivation of blood flow to the brain that manifests within seconds or minutes and transforms the body in an instant. The central truth here, which every individual and every family must hold with absolute clarity, is that aging whispers while stroke shouts, and though both may touch the same faculties of movement, speech, balance, or vision, the tempo of their arrival is what separates benign from dangerous, reversible from permanent. Consider the way aging typically presents itself. The gait of an older adult slows over years, the memory begins to falter gently, the joints stiffen little by little, and the muscles lose strength in a manner that allows the body and mind to adapt gradually. A person notices that it takes more time to rise from a chair, that carrying groceries requires more effort, that recalling a neighbor's name is slower than before, and yet all these changes enter so subtly that daily life accommodates them without shock. Stroke, however, is entirely different. Imagine lifting a cup of coffee and finding that your hand will no longer obey you, not after years of weakening, but within the blink of an eye. Imagine speaking a sentence you have spoken thousands of times and hearing your words dissolve into slurred sounds as though your tongue and lips have betrayed you. Imagine walking across a familiar room and suddenly finding one leg too heavy to lift, as though the earth itself had seized it. This is the reality of stroke, sudden, immediate, unmistakable in its speed. It is precisely this suddenness that must serve as the great warning sign. The biology behind this difference is instructive. Aging is the product of gradual cellular changes, of DNA damage accumulating, of proteins misfolding, of arteries stiffening over decades, and of organs adapting slowly to diminished reserves. Stroke, by contrast, occurs when a blood clot obstructs an artery or when a weakened vessel bursts, cutting off oxygen and nutrients to brain cells. Neurons, unlike other cells in the body, cannot survive long without oxygen, and they begin to die within minutes, which is why stroke symptoms appear so abruptly and why they progress so rapidly if untreated. This biological reality reinforces the necessity of immediate recognition, for the faster the onset, the greater the likelihood that one is dealing with stroke rather than aging. Case studies bear this out vividly. Take the story of Mr. James, a retired teacher in Ohio, who one morning reached for his coffee and found that his right hand had gone weak without warning. Within minutes, his wife observed that his speech was slurred, and they wisely chose to call emergency services. Doctors diagnosed an ischemic stroke, and because they had acted swiftly, within 3 hours, he was eligible for clot-dissolving medication. Today he continues to walk his dog and garden, living independently with only minor limitations, a future made possible by his wife's recognition of suddenness as the crucial difference. Contrast this with countless others who, when faced with similar symptoms, assumed fatigue, dismissed it as just age, and delayed seeking help until the therapeutic window had closed. For them, the difference of minutes became the difference between independence and permanent disability. It is therefore vital to instill in every household the reflexive awareness that sudden change must be treated as stroke until proven otherwise. The cultural tendency to minimize sudden symptoms is understandable but dangerous. Older adults often attribute weakness or dizziness to being tired, to medication side effects, or to the inevitability of getting older. Family members, not wishing to alarm or overreact, may encourage waiting to see if the symptom resolves. Yet this hesitation, this deferment of action, costs precious brain cells. For in stroke care there is a saying repeated often by neurologists: time is brain. With each passing minute, 2 million neurons die, and with them the capacities they govern: speech, movement, memory, personality. To appreciate the role of speed more fully, let us compare the trajectories of aging and stroke across several domains. In movement, aging leads to gradual weakness in both sides of the body, reduced muscle mass, and slower reflexes, whereas stroke produces sudden weakness or paralysis typically on one side, known as hemiparesis. In speech, aging may cause occasional forgetfulness or slower recall, but stroke can rob a person of the ability to form words or comprehend language in an instant. In vision, aging produces slow changes such as cataracts or macular degeneration, while stroke can instantly eliminate half a visual field or blur vision dramatically. In balance, aging brings mild instability over years, while stroke can render walking impossible within minutes. In every case, the dividing factor is not the system affected but the velocity of change. Moreover, speed is not only diagnostic but also prognostic. For the swifter the recognition and response, the better the chances of recovery. Treatments for ischemic stroke, such as TPA or mechanical thrombectomy, are time-dependent, effective only within narrow windows of a few hours. The same is true for hemorrhagic stroke, where immediate intervention can prevent catastrophic bleeding. Delay, by contrast, locks in damage, converting what might have been a temporary disruption into a lifelong disability. Recognizing the role of speed therefore serves two purposes: distinguishing aging from stroke and enabling timely treatment. Social education must emphasize this repeatedly, for repetition ingrains instinct. Campaigns that highlight the FAST acronym, face drooping, arm weakness, speech difficulty, time to call emergency services, are designed precisely to anchor the idea that suddenness equals danger. Yet it is not enough to know the acronym. One must be prepared to act upon it, to overcome the natural inertia that tempts people to wait and see. Waiting is the luxury of aging symptoms. It is the enemy of stroke. It is also worth noting that while speed is the clearest distinction, it is not always simple to perceive. Some strokes begin with mild symptoms that worsen over minutes or hours, and some aging-related changes may appear to accelerate suddenly under stress. This ambiguity underscores the wisdom of treating all sudden changes as potential strokes, for the risk of overreacting is negligible compared to the risk of missing the therapeutic window. No physician will fault a family for calling emergency services when in doubt, but every physician has seen the heartbreak of patients arriving too late because hesitation won. Thus, speed must not only be recognized intellectually but also felt emotionally as the central difference that demands action. To reinforce this, stories of those saved by swift action and those disabled by delay must be shared widely, for human memory clings more to stories than to statistics. In summary, the difference between aging and stroke can often be distilled to one concept: speed. Aging advances like the turning of seasons, slow and predictable, while stroke strikes like a storm, sudden and destructive. Recognizing this distinction is the key to survival, for it prompts immediate action, and in the context of stroke, immediate action is everything. The sooner one recognizes that suddenness equals emergency, the sooner one can ensure that the tragedy of stroke does not become the destiny of those we love. Among the many domains in which stroke can be distinguished from the ordinary effects of aging, none is as striking, as disorienting, and as emotionally powerful as the domain of speech and language. Human beings define themselves by their capacity to communicate. Words are not merely sounds, but vessels of memory, identity, and connection. To lose the ability to form them suddenly is therefore one of the most terrifying signs that something catastrophic is unfolding in the brain. Aging, by contrast, affects language in subtler and far slower ways, introducing hesitations, pauses, and moments of forgetfulness that, while frustrating, rarely rob a person of their ability to make themselves understood. Thus, when analyzing the difference between aging and stroke, the clues provided by speech and language are among the clearest and most urgent. Normal aging is often accompanied by what is colloquially referred to as tip-of-the-tongue moments, in which a person knows exactly what they want to say but cannot immediately retrieve the word. These moments are familiar to nearly everyone, regardless of age, but they become more common in older adults as the brain's processing speed declines and retrieval pathways are less efficient. However, given time, rest, or contextual prompts, the word usually emerges, and communication continues effectively. Likewise, older individuals may take longer to follow complex conversations, particularly in noisy environments, but comprehension of ordinary speech remains intact. These gradual changes can be annoying, yet they rarely undermine one's fundamental ability to converse. Stroke, on the other hand, brings about language disruption with stunning abruptness. Within moments, a person who is speaking normally may begin to slur words, substitute inappropriate terms, or fail to produce coherent sentences altogether. In more severe cases, known as aphasia, the person may be unable to express themselves at all, or may lose the ability to understand what others are saying, even though their hearing remains unaffected. The distinction is absolute. Aging slows language, stroke shatters it. Consider the case of Mrs. Linda from Texas, who was speaking on the phone with her daughter when her words suddenly turned into gibberish. At first, her daughter suspected static on the line, but within seconds she realized her mother could not articulate recognizable speech. Alarmed, she called emergency services immediately. At the hospital, doctors confirmed that Linda had suffered an ischemic stroke affecting the left side of her brain, specifically the region responsible for language production. Because help had been summoned quickly, Linda received treatment that minimized damage, and with rehabilitation, she regained much of her ability to speak clearly. This case illustrates both the suddenness of stroke-related language impairment and the crucial role of quick recognition in shaping the outcome. In another scenario, Mr. George, a retired accountant, had been experiencing mild word-finding difficulties for years, forgetting names occasionally and sometimes pausing longer than usual before answering. His family had grown accustomed to these moments, viewing them as part of natural aging. One evening, however, his wife noticed a profound difference. Instead of a pause or forgotten name, George attempted to speak and produce sounds entirely disconnected from meaning. Alarmed, she compared this to his usual patterns and recognized that something entirely new and sudden had occurred. Emergency intervention confirmed a stroke, and though George required therapy, his outcome was vastly better because the family recognized that this was not ordinary aging but an emergency. These stories reinforce a principle. While aging affects speech gradually, stroke overwhelms it suddenly, creating a clear boundary between normal and dangerous. The biology behind these phenomena lies in the localization of language functions in the brain. In most people, the left hemisphere houses critical regions such as Broca's area, responsible for producing speech, and Wernicke's area, responsible for comprehension. Aging affects these regions diffusely, reducing efficiency but rarely destroying function. Stroke, by contrast, can instantly deprive them of oxygen, rendering them non-functional in a matter of minutes. The difference between struggling to recall a name and being unable to say one's own name lies not in degree but in kind, and it is this difference that must be understood and respected. It is important also to differentiate between slurred speech and impaired language. Slurred speech, known as dysarthria, occurs when the muscles that control speech, such as the tongue, lips, and vocal cords, lose coordination or strength due to a stroke. In this case, the words may still be correct, but they sound garbled, heavy, or mumbled. Impaired language, or aphasia by contrast, arises when the brain's language centers are affected, leading to jumbled, nonsensical, or absent words even though the mouth muscles may be functioning. Both are sudden, both are signs of stroke, and both must be treated with equal urgency. Aging, in contrast, does not suddenly alter the mechanics of speech or obliterate comprehension. It merely slows retrieval, and reduces clarity gradually. To test whether sudden speech changes may be stroke-related, families can employ simple bedside checks. Asking the person to repeat a simple phrase, such as, "My name is John," or "It is sunny today," can reveal whether articulation and comprehension are intact. If the words come out slurred, incorrect, or absent, the suspicion of stroke must be strong. Another simple test is conversational. Ask the person a basic question, such as, "What day is it?" If they cannot respond appropriately despite being awake and alert, language disruption is likely. In all such cases, the guiding rule is to act immediately, rather than to rationalize or delay. From a social perspective, one of the tragedies of stroke-related speech problems is that they are sometimes dismissed as fatigue, intoxication, or confusion, especially in public settings. There are numerous accounts of individuals whose slurred speech was mistaken for drunkenness, leading to humiliating delays in receiving medical care. This underscores the need for broader public education, so that society as a whole becomes better at recognizing speech disruptions as medical emergencies rather than moral failings. In families, the responsibility is even more pressing, for loved ones are most likely to notice subtle differences and to act quickly. Beyond immediate recognition, it is worth considering the long-term impact of stroke on speech and language, for these outcomes highlight why prevention and swift treatment are so important. Survivors of severe aphasia often require months or years of therapy and may never regain full fluency, relying instead on gestures, writing, or assistive devices. This loss can isolate them socially, damage relationships, and erode self-esteem. By contrast, those whose strokes are treated promptly often experience only temporary deficits and recover communication fully, preserving not only their independence but also their place within the social and emotional fabric of their families. Thus, when evaluating the difference between aging and stroke in the realm of speech, one must see beyond the medical distinction and appreciate the human cost of misrecognition. In conclusion, the speech and language clues that differentiate aging from stroke are among the most compelling and essential to understand. Aging brings gradual pauses, occasional forgetfulness, and slower retrieval, while stroke arrives suddenly, producing slurred, jumbled, or absent words with alarming speed. The difference is not subtle but stark, and it carries with it a demand for action. To ignore or minimize sudden speech changes is to risk permanent loss of communication, while to recognize them promptly is to give the gift of recovery. Every individual, every family, and every community must therefore internalize this knowledge so that when speech falters suddenly, the response is immediate. Recognize stroke, call for help, and act without hesitation. For in matters of language, as in all matters of stroke, time is not only brain, but also voice, identity, and connection. Among the faculties most essential to navigating the physical world, vision and balance stand as guardians of orientation, safety, and independence. Through vision, we interpret our environment, recognize faces, and perform tasks that require precision, while balance allows us to move confidently, avoid falls, and maintain stability in both familiar and unfamiliar settings. It is in these domains that the contrast between aging and stroke once again reveals itself with clarity, for while the natural course of aging gradually reduces acuity, sharpness, and steadiness, stroke arrives with ruthless speed to disrupt these faculties in ways that are immediate, dramatic, and often devastating. To appreciate the difference, one must first understand how aging normally affects vision. Over years, the lens of the eye stiffens, producing presbyopia, which makes it difficult to focus on close objects. Many older adults begin to hold reading material at arm's length, or rely increasingly on glasses. Cataracts develop slowly, clouding the lens and reducing clarity in a progressive fashion. Macular degeneration and glaucoma may impair central or peripheral vision, but these conditions unfold over months and years, giving the brain time to adapt, sometimes so subtly that people do not notice until changes are pronounced. In each case, the progression is gradual, affecting both eyes in varying degrees but never robbing vision in a matter of moments. By contrast, stroke can steal vision suddenly and catastrophically. If a clot or bleed occurs in the occipital lobe, which houses the brain's visual processing centers, the result may be immediate loss of sight in one visual field, known as homonymous hemianopia. A person may suddenly find that they cannot see objects on one side, even though their eyes themselves are structurally sound. Others may experience sudden double vision, blurred vision, or complete blindness in one eye, depending on which blood vessels are affected. These deficits do not emerge over years. They appear in seconds, often shocking the individual who moments earlier had been seeing normally. Such abrupt change is never attributable to aging and must always raise suspicion of stroke. The same distinction applies to balance. With aging, the vestibular system in the inner ear deteriorates gradually, reflexes slow, and muscles weaken, leading to mild unsteadiness and increased risk of falls. Older adults may notice that they feel less stable in the dark, that uneven ground challenges them more than before, or that they need to rise slowly from a seated position to avoid dizziness. These changes, though inconvenient, develop slowly enough that individuals compensate through assistive devices, environmental modifications, or cautious movements. Stroke, however, disrupts balance with sudden force. When the cerebellum, brainstem, or inner ear connections are deprived of blood, coordination can vanish instantly. A person may be walking steadily one moment and collapse the next, unable to stand, veering to one side, or feeling as though the world is spinning violently. Unlike age-related unsteadiness, which is symmetrical and gradual, stroke-induced imbalance is abrupt, severe, and often accompanied by other neurological deficits, such as weakness or slurred speech. The suddenness of loss is therefore the hallmark clue. Consider the story of Mr. Harold, a 69-year-old retiree who had experienced mild vision problems for years due to cataracts. One afternoon while reading, he suddenly noticed that half the page was invisible to him, as if it had been erased. Startled, he covered one eye and then the other, but the deficit persisted on one side of his visual field. His wife, recalling a community health seminar on stroke, recognized this as a possible sign and called emergency services immediately. Doctors confirmed an occipital stroke, and because treatment was administered swiftly, Harold's vision partially returned, allowing him to continue his hobbies. Contrast this with the case of Mrs. Florence, who dismissed her sudden double vision as fatigue. She delayed seeking care, assuming it would resolve with rest. By the time she reached the hospital the next day, her stroke had progressed, leaving her with permanent deficits that severely impaired her independence. The difference between these outcomes lay not in biology, but in recognition of suddenness as the key distinction. The importance of vision and balance in daily life makes stroke-related deficits particularly dangerous. Sudden visual loss increases the risk of falls, accidents, and injuries. An individual who cannot see half their environment may walk into obstacles, misjudge distances, or fail to detect hazards. Similarly, sudden imbalance can lead to catastrophic falls, broken bones, or head injuries, compounding the damage of the stroke itself. Aging, though it increases risk gradually, does not produce such immediate threats, for people adapt by adjusting their behavior and environment. Stroke, in contrast, forces change without warning, leaving no time for adaptation. From a biological perspective, the abruptness of stroke-related vision and balance changes arises from the brain's dependence on continuous blood flow. The occipital lobe, cerebellum, and brainstem integrate sensory input from the eyes, muscles, and vestibular system to maintain orientation. When these areas are deprived of oxygen, their functions cease almost instantly, producing deficits that cannot be explained by aging alone. Aging alters tissue slowly. Stroke cuts off their lifeline in seconds. Families and communities can employ simple observational tests to detect such deficits. Asking a person to describe what they see in the room may reveal missing portions of vision. Asking them to walk a straight line or stand with feet together may reveal sudden imbalance. If these deficits appear abruptly, the suspicion of stroke must be high. Importantly, these clues are often overlooked because they may not seem as dramatic as slurred speech or facial drooping. Yet for many individuals, sudden visual loss or imbalance is the first and only warning sign. Public health education must therefore emphasize that vision and balance changes, when abrupt, are just as critical as more well-known symptoms. Beyond immediate recognition, one must also consider the long-term consequences. Vision loss following stroke can leave individuals unable to drive, read, or navigate independently, while balance problems can confine them to walkers, wheelchairs, or constant supervision. The psychological toll is immense. The loss of independence, the fear of falling, the isolation of being unable to engage in activities once enjoyed. Rehabilitation may restore some function, but the road is long, and full recovery is not guaranteed. By contrast, aging-related changes, though inconvenient, often allow adaptation and compensation, enabling older adults to continue many activities with support. This contrast highlights the urgency of recognizing and treating stroke early, for timely intervention can prevent these devastating outcomes. Socially, the sudden loss of vision or balance can also lead to misinterpretation. A person stumbling or appearing disoriented may be mistaken for being intoxicated, just as those with slurred speech often are. Such misunderstandings delay care and stigmatize individuals experiencing medical emergencies. Greater awareness is therefore essential, so that communities learn to view sudden imbalance or vision loss not as weakness or misbehavior, but as urgent signs of stroke requiring immediate attention. In conclusion, the distinction between aging and stroke in the realms of vision imbalance is once again a matter of speed and symmetry. Aging diminishes sight and steadiness gradually, allowing for compensation and adaptation. Stroke destroys them suddenly, leaving no time for adjustment and demanding urgent recognition. To attribute sudden visual loss or abrupt imbalance to fatigue, clumsiness, or age is to risk permanent disability or death. To recognize them as signs of stroke is to preserve independence, dignity, and life. Vision guides us, balance grounds us, and both depend upon the vigilance of families, communities, and individuals to distinguish the slow whisper of aging from the sudden roar of stroke. The faculties of memory and thinking constitute the essence of human identity, for it is through them that we preserve our past, interpret our present, and plan for our future. They are the instruments by which we form relationships, solve problems, and adapt to the challenges of life. When these faculties falter, the disruption reverberates far beyond the individual, affecting families, communities, and society at large. Both aging and stroke can impair memory and thinking, yet the manner in which they do so could not be more different. Aging brings a gradual, predictable decline in cognitive processing speed, recall, and multitasking, whereas stroke delivers an abrupt and often devastating blow to cognition, one that can alter personality, erase memories, and destroy reasoning within moments. To distinguish between these patterns is to understand not only biology, but also the human experience of time. In the normal course of aging, changes in memory and thinking emerge slowly. Older adults may notice that they take longer to recall names, misplace items more frequently, or struggle to keep up with fast-paced conversations. These lapses, while frustrating, are typically mild and occur intermittently, leaving overall function intact. Cognitive neuroscientists explain this as the result of reduced processing speed, diminished neurotransmitter activity, and minor atrophy in areas such as the hippocampus, which is central to memory formation. Importantly, these changes occur gradually, often so gradually that they become part of the rhythm of daily life. Families may grow accustomed to gentle forgetfulness, to the need for written reminders, and to slower problem solving. Despite these shifts, older adults remain capable of learning new skills, managing routines, and participating in complex conversations, albeit with patience and support. Stroke, however, transforms memory and thinking in an instant. Depending on the region of the brain affected, a person may suddenly lose the ability to form new memories, recall familiar information, or reason through even the simplest tasks. An ischemic stroke in the hippocampus, for instance, can render a person unable to remember what they had for breakfast, or who visited them an hour ago, while preserving long-term memories. A stroke in the frontal lobe can shatter executive functions, leaving the individual unable to plan, organize, or regulate emotions. These changes are not gradual slips, but sudden collapses, appearing within minutes of the vascular event. Unlike the creeping pace of aging, which whispers over years, stroke roars with immediacy, tearing holes in cognition that were intact just moments earlier. The human stories that illustrate these differences are poignant. Consider the case of Mr. Allen, a 75-year-old grandfather known for his sharp wit and memory. Over the years, his family had noticed small lapses, forgetting where he left his glasses, repeating a story he had told a week earlier, or struggling with new technology. These moments were minor and easily accommodated, and he remained the pillar of family discussions. Then one afternoon, while playing cards, Alan suddenly could not remember the rules of the game he had taught his grandchildren countless times. His confusion deepened as he failed to recognize the sequence of numbers, and within minutes he seemed disoriented in his own home. Alarmed, his daughter called emergency services, and doctors confirmed he had suffered a stroke in the left temporal lobe. The difference between years of slow, benign forgetfulness and the sudden disorientation of stroke could not have been clearer. Because his daughter recognized the abruptness, Alan received treatment swiftly and recovered much of his cognitive ability, though not without lingering deficits. Another account is that of Mrs. Rosa, who had lived with mild cognitive decline associated with aging. Her family was accustomed to her occasional struggles with remembering appointments or keeping track of multiple tasks. One evening, however, Rosa suddenly became unable to follow a conversation, staring blankly at her children as though the words had lost meaning. Unlike her usual forgetfulness, which was gradual and partial, this was sudden and profound. Unfortunately, the family attributed it to stress or fatigue, and by the time she was evaluated, the stroke had already inflicted permanent damage, leaving her with lasting impairments in comprehension. These stories highlight the crucial role of speed and abruptness in distinguishing aging from stroke. Biologically, the reason for this difference lies in the vulnerability of brain cells to oxygen deprivation. While aging reduces synaptic efficiency and causes gradual neuronal loss, stroke abruptly interrupts blood flow, killing neurons in concentrated areas. The brain's plasticity allows some compensation over time, but the immediate destruction produces deficits that appear without warning. The hippocampus, frontal lobes, and parietal regions are particularly susceptible, and damage to them manifests as sudden impairment in memory, reasoning, attention, or problem-solving. Importantly, the sudden cognitive deficits caused by stroke are often mistaken for dementia, particularly if the individual is already elderly. This misinterpretation is dangerous, for while dementia progresses slowly and irreversibly, stroke-related cognitive decline can sometimes be reversed or improved if treated quickly. Families and caregivers must therefore be vigilant. If memory loss or confusion arises suddenly, it is almost certainly not dementia or normal aging but stroke. An urgent intervention is required. Another critical clue lies in the pattern of deficits. Aging tends to produce generalized, mild impairments across multiple domains, whereas stroke often produces focal deficits tied to the damaged brain region. For example, a person with a left parietal stroke may lose the ability to perform calculations or recognize objects despite intact memory, while a person with frontal lobe damage may exhibit impulsivity, poor judgment, or sudden personality changes. These abrupt, localized losses are not characteristic of aging, which unfolds diffusely and gradually. The consequences of misinterpreting stroke-related cognitive decline as aging are profound. Families may fail to call emergency services, losing the opportunity for life-saving treatments. Survivors may be left with permanent disabilities that could have been prevented. The individual, once vibrant and independent, may become dependent on caregivers overnight, altering the structure of family life and imposing emotional and financial burdens. By contrast, when stroke is recognized and treated swiftly, many individuals regain significant cognitive function, preserving both their independence and their role within family and community. Beyond immediate recognition, one must also consider the long-term psychological and social effects of stroke-related cognitive impairment. Survivors often experience frustration, depression, and isolation as they struggle with memory gaps, attention deficits, and difficulty learning new tasks. Families may feel as though the personality of their loved one has changed, mourning not only lost abilities but also altered relationships. Rehabilitation through cognitive therapy, occupational therapy, and supportive environments can help, but the journey is arduous. The contrast with aging is stark. While age-related decline requires adjustments, it does not usually devastate identity in an instant. Stroke, however, can erase the thread of memory and thinking so abruptly that families are left grappling with a new reality overnight. From a societal perspective, this underscores the importance of education. Public health campaigns must emphasize that sudden confusion, memory loss, or impaired reasoning is not normal aging but a medical emergency. Communities must be trained to respond with urgency, just as they are for slurred speech or sudden weakness. By embedding this awareness in culture, countless lives and minds can be preserved. In conclusion, the difference between aging and stroke in the domain of memory and thinking is once again defined by time. Aging erodes cognition slowly, producing mild, diffuse changes that allow adaptation. Stroke obliterates cognition suddenly, producing abrupt, focal deficits that demand immediate recognition. To dismiss sudden memory loss or confusion as a sign of getting older is to risk irreversible damage, while to recognize it as stroke is to open the door to recovery. Memory and thinking are the very essence of who we are, and their preservation depends upon the vigilance of families, communities, and healthcare systems to distinguish the slow drift of aging from the sudden rupture of stroke. The distinction between aging and stroke, though clear in theory, is most powerfully illustrated through the lived experiences of individuals and families who have encountered these conditions. Real-life stories bring to life the abstract principles of neurology, revealing the human consequences of sudden versus gradual change. They allow us to see how misinterpretation of symptoms can delay care, how vigilance can save lives, and how the subtle differences between aging and stroke carry immense weight in practice. By examining case studies, both real and representative, we gain a deeper understanding of the ways in which stroke distinguishes itself from the natural aging process, not only in clinical signs, but in the human narratives that unfold around them. Consider first the story of Mr. Thomas, a 72-year-old retired teacher known for his eloquence and love of literature. Over the years, his family noticed that he occasionally forgot the names of minor characters in novels he had long cherished or misplaced his reading glasses. But these lapses were consistent with the gradual forgetfulness of aging. One evening, however, during a family dinner, Thomas suddenly found himself unable to form sentences. His words slurred, his speech slowed, and he could not articulate even simple thoughts. His family at first assumed he was fatigued or perhaps had sipped wine too quickly. But his daughter, recalling a public health message, recognized this as a potential stroke and called emergency services immediately. Doctors confirmed an ischemic stroke, and thanks to swift intervention, Thomas regained most of his speech. The distinction was plain. While aging had gently eroded recall over time, stroke had attempted to silence his voice in a matter of moments. Another case is that of Mrs. Helen, a widow in her 80s who had lived independently despite mild age-related decline in balance. She had grown cautious over the years, using a cane on uneven ground and avoiding dimly lit areas. One afternoon, while tending her garden, she suddenly collapsed, unable to stand or steady herself. Her son, assuming she had simply tripped, helped her inside and waited for her to recover. Hours later, when her condition worsened, they sought medical care. But by then, the stroke had already inflicted severe damage to her cerebellum, leaving her permanently dependent on a wheelchair. This case underscores the danger of mistaking sudden imbalance for an ordinary consequence of aging, a misjudgment that cost Helen her independence. Equally telling is the story of Mr. Samuel, a 68-year-old accountant who had always been meticulous with numbers. Over the years, he sometimes took longer to calculate mentally, a normal effect of aging, though his accuracy remained intact. One morning, however, while balancing his household budget, he suddenly could not add simple figures, nor could he recognize familiar symbols on his calculator. His wife initially dismissed it as stress or fatigue, but as his confusion deepened, she realized something more serious was at play. Doctors later diagnosed a parietal lobe stroke. The abruptness of the loss, losing skills honed over decades in mere minutes, distinguished it clearly from the slow decline of aging. These narratives are not isolated. They reflect patterns observed across communities worldwide. In many cases, families attribute sudden changes to normal aging, delaying treatment that could have reversed or reduced disability. This is particularly common when symptoms are subtle or ambiguous, such as confusion, mild speech difficulty, or imbalance. Yet every delay costs precious brain cells, for the adage, "time is brain," is never more true than in stroke. Real-life stories therefore serve as cautionary tales, teaching that suddenness is the critical marker of stroke, one that must never be dismissed as mere aging. The emotional and behavioral realm provides its own striking case studies. Mrs. Caroline, a 74-year-old former nurse, had always been calm and nurturing. After a frontal lobe stroke, however, she became uncharacteristically irritable, snapping at loved ones and displaying impulsive behavior. Her family initially believed she was simply struggling with the frustrations of aging, but medical evaluation revealed the neurological cause. With therapy and support, she gradually regained emotional stability, but the experience left her family acutely aware of how easily stroke-induced changes can be mistaken for personality shifts due to age. Another compelling story is that of Mr. Jorge, a 65-year-old shopkeeper who suddenly began laughing uncontrollably during inappropriate moments following a stroke in the brainstem. His community misinterpreted this as eccentricity or emotional instability, not realizing it was pseudobulbar affect, a direct result of neurological damage. In contrast, aging itself had never produced such abrupt behavioral shifts. Case studies from medical practice reinforce these lessons. In one hospital, 2 elderly patients arrived within hours of one another. The first, an 80-year-old man, had been experiencing gradual memory loss over several years, consistent with mild cognitive impairment. Doctors diagnosed him with early-stage dementia, and his condition was managed over time. The second, a 72-year-old woman, suddenly became disoriented, unable to recognize her own home. Initially, her family suspected dementia as well, but doctors quickly identified a stroke in the temporal lobe. While the first case reflected the slow march of aging-related disease, The second illustrated stroke's sudden theft of memory. This juxtaposition highlights the need for careful attention to the timeline of symptoms. For the same outward appearance, confusion or forgetfulness can stem from entirely different causes. The impact of recognizing stroke promptly is further illustrated in the story of Mr. Daniel, a 70-year-old grandfather who collapsed while walking with his grandson. Within minutes, his face drooped and his speech slurred. Because his grandson had learned the FAST acronym, face drooping, arm weakness, speech difficulty, time to call emergency services, at school, he recognized the signs and immediately called for help. Paramedics arrived quickly, and Daniel received clot-busting medication within the critical window. He recovered with minimal deficits, a testament to the power of recognition and swift action. This case contrasts sharply with countless others, where delays in recognition have led to irreversible disability. What these stories collectively reveal is that the key difference between aging and stroke lies not merely in the nature of symptoms, but in their onset. Aging introduces changes gradually, allowing time for adaptation and coping. Stroke delivers change abruptly, offering no time to adjust. Families who understand this principle are empowered to act decisively, saving lives and preserving quality of life. Those who misinterpret sudden changes as normal aging risk losing opportunities for treatment and rehabilitation. Beyond individual stories, case studies also highlight broader social implications. In rural areas with limited access to health care, stroke symptoms are often dismissed as aging, particularly when families lack education about neurological conditions. Public health initiatives that share stories of survivors and their experiences can bridge this gap, teaching communities to recognize sudden changes as medical emergencies. By embedding these lessons into culture, society can reduce the burden of stroke. Rehabilitation stories further illustrate the difference between aging and stroke. Mr. Patrick, a 71-year-old stroke survivor, struggled with sudden right-side weakness and speech loss. Through months of therapy, he regained much of his function, though he remained slower than before. His wife, meanwhile, experienced gradual age-related decline in her balance and memory. Together, their lives illustrated two distinct pathways. Hers, a slow adjustment to aging, his a sudden confrontation with neurological injury. Their joint story became a teaching tool for their community, reminding others that while aging cannot be avoided, stroke can be recognized and treated to minimize harm. In conclusion, real-life stories and case studies demonstrate in human terms what medical science explains in clinical language. Aging is gradual, stroke is sudden. The slurred speech of stroke is different from the occasional word-finding difficulty of aging. The sudden collapse of balance is not the same as years of cautious unsteadiness. The overnight loss of memory or personality is not the slow erosion of age. To understand this difference is to transform outcomes, for recognition and swift action can preserve speech, memory, movement, and life itself. These stories are more than anecdotes. They are lessons etched in human experience, urging us never to dismiss sudden change as normal aging, but always to consider the possibility of stroke. The difference between aging and stroke, though often subtle in appearance, carries life or death implications when it comes to response. Stroke is not a condition to be observed passively or monitored casually. It is a medical emergency in which every second matters. The brain, deprived of oxygen and nutrients due to blocked or ruptured vessels, begins to lose nearly 2 million neurons each minute. Unlike other tissues, the brain has limited ability to regenerate, and the loss is often permanent. Aging, by contrast, unfolds slowly and requires adaptation, but it does not demand the immediate mobilization of emergency services. Thus, the most critical step in distinguishing stroke from aging lies not only in recognition, but in urgent response. Understanding what to do in the first moments after symptoms appear can mean the difference between recovery and lifelong disability, between survival and death. The foundation of effective response lies in public knowledge of stroke's hallmark signs. Worldwide, health organizations have promoted the acronym FAST, face drooping, arm weakness, speech difficulty, time to call emergency services, as a simple tool to help ordinary people identify stroke. If one side of the face droops, if an arm cannot be lifted and held steady, or if speech is slurred or nonsensical, then time is of the essence. These signs are not subtle, they are sudden, dramatic, and require immediate action. Yet many communities still lack awareness, leading to tragic delays. Expanding this knowledge is therefore as important as the emergency steps themselves. Once a stroke is suspected, the first and most crucial step is to call emergency medical services without hesitation. Too often, families debate, wait, or attempt to rationalize the symptoms as fatigue, stress, or aging. Each delay narrows the window for effective treatment. For ischemic strokes, in which a blood clot blocks a vessel, clot-busting medication known as tissue plasminogen activator, TPA, must be administered within a narrow time frame, ideally within 3 to 4.5 hours of onset. In some cases, mechanical thrombectomy, physically removing the clot, can be performed within a slightly longer window, but even here, time remains critical. Hemorrhagic strokes, caused by ruptured vessels, also require urgent intervention to stop bleeding and relieve pressure on the brain. The sooner medical professionals are involved, the greater the chance of survival and recovery. Families must therefore view stroke symptoms as a command to act, not as a suggestion to observe. A common mistake is to attempt home remedies or to transport the patient in a private vehicle rather than calling an ambulance. This can be dangerous, as emergency medical services provide not only rapid transport but also immediate evaluation, stabilization, and communication with hospitals. Paramedics can begin life-saving measures en route, and hospitals can prepare stroke teams before the patient arrives. This coordinated chain of response dramatically improves outcomes. Choosing to wait or drive oneself sacrifices these advantages and can cost precious minutes. Another essential step is noting the exact time when symptoms began. Medical teams rely on this information to determine eligibility for treatments such as TPA. Families often overlook this detail in the panic of the moment, but a precise timeline can make the difference between receiving or being denied critical interventions. If symptoms began suddenly during a conversation, a meal, or a walk, that moment must be communicated clearly to medical professionals. If the onset was unwitnessed, for instance, if the patient woke up with symptoms, the last known well time must be established. These details are vital to emergency care. While waiting for help to arrive, caregivers should ensure the patient is safe. If the individual is conscious, they should be kept calm and reassured, seated or lying comfortably to avoid falls or injury. Food, drink, or medication should not be given, as swallowing may be impaired, increasing the risk of choking. If consciousness is lost, the patient should be placed on their side in the recovery position to keep the airway clear. These simple measures can preserve safety until professionals take over. Equally important is resisting the temptation to dismiss symptoms when they resolve quickly. A transient ischemic attack, TIA, often called a mini-stroke, produces stroke-like symptoms that disappear within minutes or hours. Because they resolve, many dismiss them as harmless. In reality, a TIA is a critical warning sign that a major stroke may follow soon. It should be treated as an emergency, with immediate evaluation and medical care. Recognizing this fact can prevent full-blown strokes and save lives. Public education campaigns have shown that communities equipped with this knowledge respond more effectively. For example, in cities where fast campaigns are widely promoted, emergency calls for suspected stroke have increased, and more patients receive timely treatment. Conversely, in areas without education, strokes are often mistaken for aging, intoxication, or fatigue, with devastating consequences. This underscores the social responsibility to spread awareness not only through health systems, but also through schools, workplaces, and community organizations. Children, too, can be powerful agents of recognition, as seen in cases where grandchildren have identified signs and saved their grandparents' lives. Beyond the first response, families must also understand what not to do. They must not wait to see if the symptoms will go away, must not administer over-the-counter medications, and must not assume rest will resolve the issue. Stroke is not a condition that improves with time. It worsens. Each moment without treatment compounds the damage. Similarly, one must not confuse stroke symptoms with those of aging. A person who suddenly cannot speak clearly, walk steadily, or see normally is not simply showing their age. They are experiencing a medical crisis. The psychological barrier to urgent action often lies in denial. Families may fear the implications of stroke or hope that the problem will disappear on its own. Overcoming this denial requires education and repeated reinforcement that stroke is a time-sensitive emergency. Stories of survivors who acted quickly and recovered can inspire others to respond without hesitation. At the hospital, the emergency steps continue with rapid assessment, including imaging to determine whether the stroke is ischemic or hemorrhagic. Treatment follows immediately, guided by the type and timing of the stroke. But all of this depends on the first link in the chain, the recognition and action taken by family members, bystanders, or even the patients themselves. The community is, in many ways, the first line of defense against stroke's devastating impact. In rural and underserved areas, where access to emergency services may be limited, the challenge is even greater. Families may rely on local transportation, and delays are common. In such settings, community education becomes even more vital. Training lay people to recognize symptoms, prioritize immediate action, and use whatever means are fastest to reach medical care can bridge some of the gap. Mobile stroke units, telemedicine, and outreach programs have shown promise in reducing delays, but their effectiveness depends on communities recognizing the emergency in the first place. In conclusion, the response to stroke must be immediate, decisive, and informed. Aging requires adaptation and patience, but stroke demands urgency. The hallmark of stroke is suddenness, and sudden changes in speech, vision, balance, strength, or cognition must be treated as medical emergencies, not as natural consequences of aging. The steps are clear. Recognize the signs, call emergency services, note the time of onset, keep the patient safe, and resist denial or delay. These steps, though simple, hold the power to preserve lives, protect independence, and prevent disability. They transform recognition into action, theory into practice, and knowledge into survival. To understand how to respond is not only to protect oneself and one's family, but also to contribute to a culture of vigilance, in which stroke is never mistaken for aging and never ignored when swift action can make all the difference. When considering the difference between aging and stroke, one cannot overlook the indispensable role of family and community in shaping outcomes. Medicine provides treatments, hospitals deliver acute care, and rehabilitation offers structured recovery. But it is families and communities who stand closest to individuals when signs first appear, who make the critical decision to call for help, and who support the long journey of recovery. Their role is therefore not supplementary but central, for in many cases it is the vigilance of a loved one, or the awareness of a neighbor that determines whether a stroke is recognized in time or mistaken for the slow march of aging. To understand this role fully, one must examine not only the immediate moment of crisis, but also the long-term responsibilities and the cultural context that influence how families and communities respond. At the moment a stroke occurs, the family is often the first witness. It is a spouse who notices that their partner's smile appears lopsided, a child who observes slurred speech, or a grandchild who sees an arm drift downward when lifted. If these witnesses interpret the symptoms as fatigue, stress, or aging, precious time is lost. If they recognize the signs as stroke and act immediately, the individual has a far greater chance of recovery. Thus, education within families is critical. Every household that includes older adults should know the FAST acronym, should understand that suddenness distinguishes stroke from aging, and should be prepared to call emergency services without hesitation. This is not merely a matter of medical knowledge, but of love expressed through vigilance. Communities too have a role in this first stage. In many parts of the world, individuals spend as much time in the company of neighbors, colleagues, or fellow worshipers as they do with family. A stroke may first manifest at a community gathering, during a walk with friends, or at a place of worship. In these settings, the community becomes the first responder. When communities are educated to recognize stroke, they can save lives. When they are not, symptoms are dismissed, and tragedies unfold. Public health campaigns, therefore, must not only target individuals but entire communities, embedding stroke awareness into collective consciousness, just as fire safety and first aid are widely understood. Beyond recognition and emergency response, families bear the burden of care during recovery. Stroke survivors often leave the hospital with significant disabilities, weakness, speech difficulties, memory problems, or behavioral changes. Professional rehabilitation is essential, but it is families who manage daily routines, assist with mobility, encourage therapy, and provide emotional support. This role requires patience, resilience, and knowledge, for caring for a stroke survivor can be emotionally and physically demanding. Aging, by contrast, usually allows for gradual adaptation. Families can adjust over time to changes in mobility or cognition. Stroke, however, imposes immediate and often drastic demands. Families must reorganize their lives overnight, shifting roles, responsibilities, and resources to accommodate new realities. The community's role in recovery is equally vital. Neighbors who check in, community groups that provide support, and local organizations that offer resources can ease the burden on families. Social interaction itself is a form of rehabilitation, helping survivors regain confidence, practice communication, and combat isolation. Communities that stigmatize or withdraw from stroke survivors compound the harm, while those that embrace and support them become instruments of healing. Education, empathy, and inclusion are therefore as critical as medical therapy. Culturally, the way families and communities respond to stroke is shaped by beliefs about aging. In some societies, sudden weakness or confusion is dismissed as simply old age, leading to delays in seeking medical help. In others, there may be fatalistic attitudes, viewing stroke as inevitable or untreatable. These cultural narratives can be as dangerous as the stroke itself, for they discourage urgent response. Shifting these beliefs requires sustained public health efforts that respect cultural values while promoting accurate knowledge. Stories of survivors who recovered through timely intervention can be powerful tools in changing perceptions, showing that stroke is not destiny, but a condition that can be mitigated through swift action. The role of family also extends into advocacy. Families who have experienced stroke often become advocates for awareness, sharing their stories in schools, workplaces, and communities. Their testimonies carry a weight that statistics alone cannot, transforming abstract information into lived reality. Communities that empower such voices build resilience against stroke, equipping more families to respond effectively when the time comes. In addition, families and communities provide the emotional scaffolding that sustains survivors through long recoveries. Stroke often strips individuals of independence, altering identity and self-esteem. Survivors may feel frustrated, isolated, or depressed. Here, the encouragement of loved ones, the patience of caregivers, and the presence of community can make the difference between despair and perseverance. Support groups, religious communities, and neighborhood networks provide a sense of belonging that medical treatment alone cannot offer. Aging, though it requires companionship, rarely produces such abrupt emotional crises, highlighting again the unique demands of stroke. Economically, families often shoulder significant burdens following a stroke. Lost income, medical expenses, and caregiving responsibilities strain resources. Communities that provide practical support, transportation, meal delivery, financial assistance, lighten these burdens. Policymakers, too, play a role in empowering families through accessible healthcare, rehabilitation services, and caregiver support programs. Without these systems, families may be overwhelmed, and survivors may languish without adequate care. Thus, the role of community extends beyond social interaction into structural support, ensuring that the weight of stroke does not fall solely on individual households. The role of family and community is also preventative. Families who encourage healthy lifestyles, balanced diets, exercise, regular checkups, help reduce stroke risk. Communities that provide safe spaces for activity, affordable healthcare, and education foster resilience against both stroke and the challenges of aging. Prevention is not solely a medical endeavor, but a cultural and communal one, rooted in habits, environments, and shared values. By nurturing these, families and communities serve not only as responders, but as protectors. Case studies reveal the transformative power of family and community in stroke response. In one instance, a grandson who had learned the FAST acronym at school recognized his grandfather's slurred speech as a stroke sign and called emergency services, saving his life. In another, a church community rallied around a stroke survivor, providing meals, transportation, and companionship, enabling recovery that might otherwise have been impossible. These stories remind us that while medicine provides tools, it is people, families, friends, neighbors, who wield them in the crucial first moments and sustain them in the long aftermath. In conclusion, the role of family and community in distinguishing stroke from aging is profound and irreplaceable. Families are the first to notice, the first to respond, and the primary source of ongoing care. Communities amplify this support, providing education, empathy, and resources that shape outcomes. Aging may challenge families gradually, but stroke confronts them suddenly, demanding knowledge, decisiveness, and endurance. To prepare families and communities for this role is to build a safety net that medicine alone cannot provide. It is to recognize that the battle against stroke is fought not only in hospitals, but in homes, neighborhoods, and cultural narratives. By equipping families with knowledge, fostering supportive communities, and reshaping cultural attitudes, society can transform outcomes, preserving not only lives but the dignity, independence, and humanity of those touched by stroke. In reflecting on the differences between aging and stroke, it becomes clear that while the two may share certain outward signs, such as slower movement, diminished memory, or altered speech, the nature of their progression, their consequences, and above all their demands for response are profoundly different. Aging is an inevitable biological process, unfolding gradually over time, offering individuals and families the opportunity to adapt, plan, and accept. Stroke, on the other hand, is an acute medical emergency, a violent interruption of normal function, and a sudden disruption that can dismantle a person's independence in minutes. To confuse one for the other is to risk irreversible harm. For where aging requires patience and adjustment, stroke requires urgency and decisive action. This distinction forms the core of our discussion, reminding us that recognition and response are not merely medical concepts but moral responsibilities. To understand aging is to embrace the arc of life. To understand stroke is to confront the fragility of that arc and the pressing need to preserve it through swift intervention. The conclusion of this exploration rests on three interwoven truths: the importance of knowledge, the necessity of preparedness, and the power of community. Knowledge is the first and most fundamental defense. When families and communities know that sudden changes, whether in speech, vision, strength, or balance, signal stroke rather than aging, they are empowered to act. Awareness campaigns, educational initiatives, and the widespread promotion of simple tools, such as the FAST acronym, equip ordinary people with the ability to save extraordinary lives. Knowledge transforms fear into action, confusion into clarity, hesitation into decisiveness. Yet knowledge alone is insufficient unless paired with preparedness. Preparedness means not only recognizing symptoms, but also knowing the steps to take, calling emergency services immediately, noting the time of onset, ensuring safety while awaiting help, and resisting the urge to dismiss or delay. It also means preparing emotionally and practically for the possibility of stroke within families, especially those with older members or those with risk factors. Preparedness transforms knowledge into practice, ensuring that recognition is followed by the swift actions that make recovery possible. The final truth lies in the power of community. No individual or family bears the weight of stroke alone. Rather, they are embedded within social networks that either strengthen or weaken their capacity to respond and recover. Communities that spread awareness, that support families in crisis, that welcome survivors with compassion rather than stigma, are communities that save lives and foster healing. Policymakers, educators, religious institutions, and civic organizations all have roles to play in embedding stroke awareness into the fabric of society. In such communities, the difference between aging and stroke is not merely known but acted upon, not merely acknowledged but lived. At a deeper level, the distinction between aging and stroke also reminds us of the fragility of human life and the responsibility we share in protecting it. Aging teaches us to accept change, to honor the passage of time, and to adapt with grace. Stroke teaches us the urgency of action, the preciousness of each moment, and the profound consequences of delay. Together they illustrate the spectrum of human vulnerability. One slow and expected, the other sudden and devastating, but both demanding compassion, wisdom, and vigilance. By honoring this distinction, we not only safeguard health, but also affirm dignity, refusing to allow preventable harm to masquerade as natural decline. The conclusion, therefore, is not only academic but practical and ethical. We must educate ourselves and others, prepare for emergencies, and strengthen communities. We must teach children the signs of stroke, empower caregivers with knowledge, and encourage policymakers to invest in awareness and infrastructure. We must remind ourselves constantly that stroke is not aging and that time is life. Only by embedding these truths into daily consciousness can we hope to reduce the toll of stroke and preserve the independence and vitality that aging, when supported, still allows. Ultimately, this exploration has revealed that the line between aging and stroke is not as blurry as it may seem. The suddenness, severity, and urgency of stroke set it apart decisively from the gradual, predictable course of aging. The challenge lies not in the medical distinctions, which are clear, but in the human perception of them, which is often clouded by denial, ignorance, or cultural beliefs. By addressing these perceptions head-on, by equipping families with tools, and by fostering communities of vigilance, we transform vulnerability into resilience. The broader implication of this discussion extends beyond stroke itself. It speaks to the importance of distinguishing the normal from the pathological, the gradual from the sudden, the inevitable from the preventable. It reminds us that while life's course carries natural challenges, not all decline is natural, and not all suffering is inevitable. Some crises can be averted, mitigated, or transformed through knowledge and action. In recognizing this, we reclaim agency over our health and reaffirm the value of every moment preserved. In conclusion, aging and stroke intersect in outward appearance but diverge in essence. One is the story of life's gradual unfolding, the other an abrupt rupture of that story. To mistake one for the other is to surrender to preventable loss. To distinguish them is to preserve possibility. Our task, then, is clear: to educate, to prepare, and to support. Families must be vigilant, communities must be engaged, and societies must prioritize awareness. By doing so, we honor both the natural process of aging and the urgent imperative of preventing stroke's devastation. In the end, the measure of our response is not only in lives saved, but in dignity preserved, independence protected, and humanity upheld. That is the ultimate difference between aging and stroke, not merely in biology, but in how we, as individuals, families, and communities, choose to respond.